welcome everybody to our webinar titled Privacy and Confidentiality Protections for Research Participants, Revisions of the 42 CFR Part 2 Proposed Rule. Our speaker this afternoon is Dr. Maureen Boyle. She joined NIDA almost 2 years ago. She is the Chief of the Science Policy Branch in NIDA's Office of Science, Policy, and Communications, and prior to that she was at SAMHSA as the Lead Public Health Advisor for Health Information Technology, where she promoted the use of technology to improve the delivery of substance use treatment. She also worked in this proposed rule while she was there. So she has a lot to offer about this proposed changes. She has a PhD from from Washington University in St. Louis, and also did a fellowship at the NIH Office of Behavioral and Social Science Research. The objective this afternoon is to describe the basic privacy protections afforded by the 42 CFR Part 2, what information is protected and to whom the information is applied, the review of the proposed changes of the 42.2 as substance abuse treatment becomes increasingly available in non-traditional medical settings, and consider the implications of these proposed changes to the substance use data flow between health organizations for research and medical records. With that, I would like to ask Dr. Maureen Boyle to start her presentation, and we hope to have plenty of time for questions and discussions at the end. Thank you, everybody.
Great. Thank you, Carmen, and good afternoon, everyone. As Carmen mentioned, I'm going to give an overview of 42 CFR Part 2 and the proposed revisions that SAMHSA has put out in their Notice of Proposed Rulemaking. So first, I just wanted to give a initial overview of the current 42 CFR Part 2, which are basically regulations that govern the confidentiality of substance use disorder treatment records. And the purpose of these regulations was to encourage patients to seek substance abuse treatment without fearing that they're going to be compromising their privacy by doing so. But it's important to emphasize that these regulations are not meant to prevent the sharing of information, but to set the standards for how we share information and to make sure that patients have the choice and the agency in that decision. So the federal laws are a baseline, and states are free to adopt more strict regulations. However, most states, as far as substance abuse treatment records, don't adopt stricter standards than the federal regulation. But state laws do vary pretty widely around mental health information privacy. So SAMHSA is currently working on updating the regulations. The statute for these regulations was written in 1975, and the regulations were last updated in 1987. And obviously there have been very significant changes to the healthcare system across the United States in that time that weren't envisioned by these regulations. So including things like the expansion of electronic health records, health information exchange organizations, and new models of integrated care that have complicated compliance with these regulations. So I included a link here to the Federal Register notice for the Notice of Proposed Rulemaking. And in case anybody's interested in making comments, they're due by 5 p.m. Eastern Time, April the 11th. So 42 CFR Part 2 applies to federally assisted organizations or individuals that hold themselves out as providing alcohol and drug abuse treatment, diagnosis, or referral to treatment. And basically what these regulations do is they say that with limited exceptions, patient consent has to be obtained before you share information from a substance use disorder treatment facility that we call a Part 2 program with anyone outside of that facility. So the proposed updates to the applicability of the regulations are relatively minor, and I know that SAMHSA gave a lot of thought to how to change these regulations to make the kind of applicability a little bit simpler, but in the end, this was, I think the end conclusion was basically that this is the best way to go for now. And so basically, they defined a program as either an individual or entity that holds themselves out, as I said before, as providing substance use disorder treatment, diagnosis, or referral. It also includes identified units within a general medical facility or general medical practice that hold themselves out as providing these services, or an individual personnel or other staff that whose primary function is the provision of these services. And this is the proposed language is a very minor change that's really more of a clarification of the current applicability. In addition, in the preamble to the rule, SAMHSA proposes a definition of what it means to hold oneself out. And they basically make it clear that general medical providers that are providing substance use disorder treatment services during the provision of general health care do not fall under this rule. But some of the issues around applicability are basically that we're unable to kind of consistently identify what information are covered by Part 2. And the status of a Part 2 organization can change over time. So depending on whether an organization advertises or in some other way holds themselves out to the public as providing these services, is obviously adaptable over time. And so kind of an issue with the current rule has been the inability to kind of say, okay, here are all the Part 2 programs and here's all the data that they collect, and so we know exactly what should be protected, especially in kind of large billing databases. And this rule won't address that. But basically the rule says that with limited exceptions, patient consent has to be obtained before sharing information from the Part 2 programs. And the disclosure of this information is basically any information that identifies an individual as receiving services from a Part 2 program. So even acknowledging that an individual is or was a patient at a Part 2 program is a breach of the regulations. The current notice of proposed rulemaking clarifies this to make it clear that this only applies to information that would reveal that an individual has or has had a substance use disorder. So in other words, if it's a facility that also provides other services, mental health services, general health care services, then that organization would be able to share information that pertains to those treatment services, as long as it didn't reveal that the individual had a substance use disorder. And there are a number of exceptions built into the rule for disclosure without consent. And that includes things like medical emergencies, and most importantly for this call, public health research, audits, and evaluations. The rule also provides very detailed requirements for the consent that can be obtained to share information. So the current rule has 9 required elements of the consent form, including who the information is coming from, who's it going to, the purpose, the amount and kind of information, an expiration, et cetera. And the most problematic aspect of this from the purposes of integrating care, and one of the main reasons why SAMHSA is proposing to update the rule, is the to whom section, which in the current regulations indicates that the consent has to include the name or the title of the individual or the organization to whom the disclosure is going to be made. And within the context of health information exchange organizations or accountable care organizations whose membership is growing over time, this has basically caused complications where you have to either constantly update the patient's consent, or what has happened in reality is that these organizations simply don't include behavioral health. They don't incorporate information from Part 2 programs. And so SAMHSA is proposing to allow the consent to use a general designation in the to whom section. That would include basically saying my treating provider, and that they would also at the same time require that the from whom section specifically name the Part 2 program. And the intent of this is to make sure that the patient truly understands that, that it is their substance use treatment information that they're consenting to allow to be shared. They have, in the proposed rule, they do limit the use of the general designation to only when a treatment provider relationship exists. And in addition to that, it basically indicates that if you're going to, if someone's using the general designation, that the patient would have to be able to access a list of the individuals who have accessed their records. And SAMHSA is also seeking comments on a potential alternative approach. So instead of adapting the from whom and to whom sections, they asked for comments on whether an alternative would be to define the word organization more broadly, specifically as an organization that's a treating provider of the patient whose information is being disclosed, an organization that's a third-party payer that requires patient identifying information, or an organization that's not a treating provider of the patient whose information is being disclosed, but that serves as an intermediary. One of the issues with both of these for research is that neither of them would allow kind of a broad consent for research purposes, for, like as an example, for researchers utilizing a large database. So for example, with the Precision Medicine Initiative cohort, the intent is to build a large research data cohort that can be accessed for many different types of research. And so this definition wouldn't allow for a broad consent to allow kind of any qualified researcher to access that data. Although additional provisions that I'll get to in a minute could help address that use case. In addition, the rule makes it clear that the patient has the right to revoke their consent at any time, and that would apply to any information, the consent that, unless it has already been acted upon. And this can be important to consider for things like the Precision Medicine Initiative and other kind of research databases in terms of how those databases are going to be implemented in order to allow the patient to revoke their consent. In addition, the Part 2 rule requires that every disclosure include a specific notice on the prohibition on redisclosure that lets the receiver know that these regulations prohibit them from making any further disclosure of the information that they've received unless it's expressly permitted by a Part 2 compliant consent. In the proposed rule, they basically provide some new language for that prohibition on redisclosure, as I had mentioned before, to make it more clear that it's not any information that an individual would receive that's prohibited to be redisclosed. It's information that would identify the patient as having or having had a substance use disorder, alone or in reference to other publicly available information. And the Part 2 rule also includes provisions for sharing patient identifiable information for research purposes. And the current rule basically states that only the Part 2 program director can make the determination to share this information for research purposes. And this is basically done by determining that the researcher is qualified and having a review of the protocol by 3 or more qualified individuals. And the rule indicates that PII can only be disclosed back to the program from which the information was obtained. although de-identified information can obviously be shared through publications and other materials. So the proposed updates in the rule would expand that provision to allow any individual or entity that's in lawful possession of Part 2 data to share the information for research purposes as long as certain criteria were met. And that's basically that they're in compliance with the HIPAA privacy rule, that they're in compliance with the common rule, and they're in compliance with their local IRB or privacy board. And this is a really important provision because in the current landscape, there are many of these types of organizations that collect information from multiple Part 2 programs. So the health information exchanges, accountable care organizations, many other types of coordinated care organizations across the country, and this allows them to make those data available for research purposes. And in addition to that, SAMHSA is proposing to make researchers more responsible for making sure that they comply with 42 CFR Part 2. So they add some language to indicate that researchers who receive information that are subject to Part 2 need to be fully bound by these regulations. And similar to treatment providers, they need to resist judicial proceedings that attempt to obtain the patient records, which basically means that in addition to a subpoena, a court order is required to compel the release of information that's subject to Part 2. In addition, SAMHSA has included some language around linking disparate data sets. So they're adding a new section to the proposal that would talk about how you merge data sets. However, the information that they, or the language that they include in here limits this linkage proposal to federal or federally approved data repositories that have a data use agreement in place that's been approved by a federal privacy board. But SAMHSA includes in the Notice of Proposed Rulemaking a number of questions for researchers and others who would look to kind of merge different data sets on whether this proposal should be expanded and whether there are kind of any concerns about the current language that they're proposing. From my perspective, I think there are some kind of just confusion in the language that's provided in the Notice of Proposed Rulemaking, and so I think it would be good for researchers to provide some feedback on how to clarify that. In addition, the proposed language states that except as provided in this paragraph, the researchers can't use patient identifying information to link data, and that seems a little narrow. So, we would recommend that researchers take a close look at the provisions that are listed in there and provide feedback to SAMHSA. In addition, there is an audit and evaluation exception for the consent requirements. So in the current, as well as the proposed regulations, only the Part 2 program director can make the determination to share data for the purposes of an audit or an evaluation, and only on site. So, the Notice of Proposed Rulemaking proposes to permit data sharing for these purposes with, again, kind of just a limited set, specifically with CMS and CMS regulated qualified entities. And so the purpose of that provision would be to address the current issue that's been going on where CMS has been redacting substance use treatment information from their publicly available research data sets. So this would directly address that problem, and it would allow CMS to make kind of the full gamut of health information available to researchers. However, it wouldn't address other lawful holders of Part 2 information and allow them to to allow an audit or an evaluation. So for an example, either health information exchange organizations or managed care organizations other than CMS regulated organizations would need to get authorization from each of the contributing Part 2 programs in order to authorize an audit or an evaluation. And so from NIDA's perspective, since these type of evaluations can kind of be a precursor to research, we think it's important to look at whether this can be expanded to include kind of lawful holders of information, similar to what was done with the new proposed language for the research provision. And I also just wanted to highlight some available standards that are being developed to help facilitate the electronic sharing of information that's subject to privacy rules. So the Office of the National Coordinator for Health IT, as well as SAMHSA and a number of external partners for the last few years have been working on an initiative called Data Segmentation for Privacy. And this initiative helped to develop standardized metadata for electronically sharing information that's subject to a vast array of privacy protections. And they set the standards for how those kind of packages of information can be shared that includes kind of all of the information that the system would need to interpret what type of protections need to be in place for the data that are incorporated. And SAMHSA has been working on an open source tool called Consent to Share that basically applies these metadata standards into an available software tool that can manage an individual's consent and incorporate the obligations that are associated with that information, and send it either as a full record or with specific information redacted if that's appropriate to the situation. And this is just kind of an overview of the privacy metadata that have been developed through that process. And this is an HL7 a standard document. So it includes kind of the information, all of the elements of the Part 2 consent that we talked about before, the purpose of use, whether tagging it for whether a notice of redisclosure is appropriate or of non-redisclosure is appropriate, the obligations that are associated with receiving that information, et cetera. So I've included in this slide just a link to those resources so that anyone who's interested in using those standards can access them, as well as the current frequently asked questions on Part 2 that were developed by SAMHSA. And obviously this applies to the current rule and not to the proposed rule. And again, a series of webinars that were done by the Legal Action Center on more details of 42 CFR Part 2 that are a very good overview, although again, this applies to the current regulations and not the proposed rule. And now we can open it up for questions.
So we have two questions in the chat.
Okay.
The first one is from Rulin Hatcher, and it's for data exchange within one healthcare organization that uses EMR. Would the proposed changes make the electronic information exchange possible through an EMR between primary care and addiction treating providers within the same organization? And Part 2 of that, what process is needed in this case?
In general, in the use case that you're describing, it would be a single organization, but the unit within that organization that provides substance use treatment services, if they're holding themselves out as doing that, would likely be covered by Part 2, and the primary healthcare organization wouldn't. And so sharing information between those two units would require patient consent. And that can happen through the electronic health record as long as kind of all of the consent requirements are met. As I noted before, kind of these metadata standards are available to facilitate that in an electronic health record context.
Okay, and we have another question in the chat from one of our investigators, Todd. It says, regarding slide number 6, can you please clarify if A, primary care providers prescribing MAT, and B, an inpatient addiction medicine consult service are considered Part 2 providers? 42 CFR Part 2 will greatly impair EHR documentation and care coordination in these settings without a number of modifications.
Yes, and this was a significant concern of SAMHSA when they were putting together this rule, because they wanted to make sure that any changes to the rule don't cause primary care providers to decide not to prescribe buprenorphine or for medication-assisted treatment for their patients. And so the current rule basically would not apply to primary care providers who are providing MAT in the context of primary care. However, if you had a primary care office where you had, say one individual who only provided substance use treatment and held him or herself out as providing those services, that individual or unit, depending on how it's structured, could be, if they're federally assisted, subject to 42 CFR Part 2. And federally, which I probably should have discussed earlier, but federally assisted, so the applicability of Part 2 is basically a federally assisted organization that holds themselves out as providing substance use treatment services. And federally assisted is incredibly broad. So it's, if they accept Medicaid or Medicare, if they have a DEA license, if they have a tax-exempt status, kind of any type of federal certification applies. So in the case that you're talking about, if it's in the provision of general health care services, they wouldn't be covered. If they are if their primary function is the provision of substance use treatment services and they hold themselves out as such, then they would be covered. And the second question was kind of in the context of an inpatient addiction consult. I'm not sure that I think I might have to think that use case through. I think if you are simply bringing someone in as a consult and that consulting physician is not the treatment provider of the individual, then that wouldn't be covered by Part 2. But if the patient were kind of seen as a patient of that inpatient addiction treatment center, then the information that was collected through that process would be covered by Part 2.
Okay, great. Gavin Bart, I see that your hand is raised. Go ahead and ask your question, please.
Great. Thank you, Maureen, for your presentation. One of the areas that's very consternating is really understanding what holding oneself out to be means. So going on Todd's question, there are approximately 4,000 diplomats of the American Board of Addiction Medicine. Many of them are primary care providers who, in the delivery of primary care, are prescribing medication, but because they also happen to have a board certification in addiction medicine, does that mean they are holding themselves out to be, even though they're doing it in the context of providing primary care?
That's a very good question.
Complicated.
Yes, and I think that could be something to kind of incorporate into comments to SAMHSA on the rule, to ask them to, in the preamble, to kind of define that a little bit more in that context. I think that is something that I have heard kind of referenced before. I think holding yourself out can include things like advertising, putting yourself on a kind of a search engine for opioid treatment providers, or that type of thing could be construed as holding yourself out. I think in the instance that you're talking about, when that individual is providing primary care services and is not kind of primarily only handling individuals with substance use disorders, I believe SAMHSA's intent is for those individuals to not be covered by 42 CFR Part 2. But I agree with you that could be something that is clarified in the final rule.
So in a specific example, let's say me, I'm an internist. On Mondays, Wednesdays, and Fridays, I do general internal medicine clinic, and sometimes on those patients in the clinic, I will prescribe MAT. But on Tuesdays and Thursdays, because I'm an addiction specialist as well, I see patients strictly providing MAT. So am I covered on Tuesdays and Thursdays but not covered on Monday, Wednesdays, and Fridays, even though I am holding myself out in general, especially on Tuesdays and Thursdays, as being a specialist?
Yeah. I mean, I think the way that I think about it is if somebody were looking at kind of publicly available information, would their conclusion be that you primarily provide substance use treatment services, or would the conclusion be that you are you're an internist and a primary care physician? And this is where, as I said before, it gets pretty complicated, and it precludes us and others from kind of generating a static list of who are the Part 2 providers and what specific information needs to be protected. And a lot of this kind of ends up being you as a physician end up making that call of whether you're a Part 2 program. But yeah, I don't have a conclusive answer to that question.
All right. We do have another question in the queue. In a HMO organization, a patient can see different primary care providers and specialists. So the current rules still will prevent information exchange easily between addiction providers and the primary care and specialty care providers if a specific name of the information receiver should be specified in the consent. Is that correct?
So no, that's actually what the rule is intended to address. And so the current rule requires that a specific name or organization's name be included. But the proposed rule basically allows the consent to include a general designation. So in the context that you're talking about, where you want the primary care side to be communicating with the Part 2 program, the patient needs to sign a consent that would say, I am, that they're okay with information from that Part 2 program being shared with any of their treatment providers in that HMO organization. And so that would allow kind of, even if the treatment providers change over time, that consent is still valid and can be used to share information with their treatment providers. And the onus is really on that organization to have some sort of process for verifying that somebody is a treating provider. So whether there's an attestation, in the electronic health record when somebody goes to access the record and they have to kind of attest that they're a treatment provider, or whether the system looks to see if the patient has made an appointment with this provider. So there's flexibility in how that's implemented, but a single consent can be that broad under the new rule.
Okay, that'll complete all of our questions in the queue. Any more questions? Use your virtual raised hand button, please.
And just while anything is coming in, I will just reiterate that I would encourage everyone to send in these questions and their comments on the proposed rule by April 11th.
Gavin, you're back on.
Hey, Maureen, I've got a question about the meta tags.
Yes.
Are they widely available at this point? Because one of the things we're having difficulty with is EHR seems to be able to adequately hide or sequester access to notes related to covered entity encounters. But what we have very difficult time with is hiding other factors. So if the person shows up to the treatment facility and says, I have a new phone number, and the phone number gets updated in the EHR, there's always an audit trail of who and where that phone number was updated. And we don't have a good way of hiding that information. Do the data tags extend to that type of metadata, the metadata that tracks the origin of chart changes?
Yeah, I mean, I would think an EHR organization, an EHR vendor could implement that type of functionality. Part of the problem has been that one, EHR vendors have been under kind of constant pressure to to update their systems to comply with the meaningful use rules, and that's kind of made it difficult to get kind of other types of functionality incorporated that aren't necessary for meeting that rule. And from the behavioral health perspective, behavioral health has, because it wasn't incorporated in meaningful use, has kind of even more fallen behind. So I think that's something that that many of these EHR systems can do, although if they want to put the resources towards that. Although there are a handful of even some of the larger vendors who, like Epic, like the VA system, that are built in a way where they can't easily incorporate metadata. Because the systems were built decades ago on what is now pretty antiquated technology, and so these systems can't kind of easily be adapted to the current workflow. But many of these systems, and especially ones that have the capacity to incorporate metadata, should be able to do that if they want to put the resources towards it.
Dennis McCarty had a comment in the chat, and then we can get to Todd's question. So Dennis says, SAMHSA's impact analysis says that it cannot estimate the number of practitioners that might be covered, but it goes on to note that there are 220 health information exchanges, 750 ACOs, and 7,000 patient-centered medical homes. It feels like SAMHSA sees all of these entities as potentially covered.
I'm not sure if they would see those entities as potentially covered under the Part 2 rule as much as there are implications in the rule that apply to them. So in the context of, say, the health information exchanges, none of those would be Part 2 programs, but some of the provisions in the rule would apply to them and really are intended to facilitate incorporating behavioral health information within the health information exchange organizations. And, I think, probably within the context of the ACOs and the patient-centered medical homes, if they're incorporating, specialty substance use treatment services within there, then, I think the leap would be that there probably are units or individuals within those kind of vast organizations that would be covered under the Part 2 rule. And that would be my guess. But again, that's, without speaking for SAMHSA, that would be my guess.
Okay, Todd, you're on.
Thank you, Maureen, for clarifying some of these issues. Coming back to the inpatient medicine consult service, which could potentially be a nice platform for CTN and other trials down the road, I'm still not clear on applicability of Part 2 to the addiction medicine consults. We're clearly holding ourselves out as offering addiction medicine services in a consultative capacity to the primary team. And the way we've locally interpreted that is just to put a disclaimer at the top of each consult note. But the primary team then incorporates the addiction diagnoses, et cetera, some of the treatment plan into their own notes each day. So as we think about how to operationalize this in an EHR, considered protected under Part 2, or is it only the addiction consult note, or are we making too big of a deal of all of this and none of this really applies because it's happening in general healthcare settings?
Yeah, I mean, I think it, I think that's definitely something that I would go to SAMHSA or a lawyer with. I mean, the things that that I would be asking in that context are, one, does that consulting physician have an appointment with the patient, or is it the primary care provider is consulting with you in the context of that patient? And then, in addition to just the, what's the strict interpretation of the rule, there's also kind of the, ethical and kind of general privacy concerns of the patient. So part of that can be, do you think that your patients would be more comfortable being open and honest about their substance use issues, if they felt like there were privacy protections in place to make sure that if they, revealed particularly sensitive information, that it wouldn't be, just available in the primary care record with kind of the minimal HIPAA protections. But, in that context, because I think, it wasn't something that explicitly came up when I was at SAMHSA, and I think it is kind of an important complexity for them to address in the new rule. I think it would be worth sending comments to them and asking for them to clarify that within the final rule that comes out.
Thanks so much.
And Carmen also wanted to ask, is there a potential for SAMHSA to extend the due date for comments?
I highly doubt that, but I haven't heard anything about that. I know SAMHSA is hoping, although given a rule this complex and somewhat controversial, they're hoping to release the new rule or the final rule by the end of this year. I think that'll be a very tight deadline for them to make, and will depend on kind of the number of comments that they get in. But I'm not sure. Do you know if there's been kind of concerns from the community about not having enough time to comment?
No, I'm just asking in general because I have noticed recently that other proposal rulemakings have extended their time. I have no idea if SAMHSA has received any comments asking or requests asking for that.
Yeah, not that I've heard of either.
So this is Gavin again. I'm just wondering if you can help clarify about how the comment period works, because my understanding is they won't necessarily address comments regarding the rule as a whole, but that they will only address comments about the proposed changes. Is that correct, or are they going to address comments about the rule as a whole?
So in general, what they try to do is address the broad scope. So they don't address individual comments, but they address the kind of the broad scope of the comments that they've heard. And the general rule with regulations is that that the notice of proposed rulemaking needs to basically include any of the proposed changes that would make it into the final rule, or that by reading the notice of proposed rulemaking, any changes that make it into the final rule are kind of a logical extension of what is discussed in that notice of proposed rulemaking. So SAMHSA is somewhat limited to in that context, that people having read the notice of proposed rulemaking really will have had a sense of what SAMHSA, the direction that SAMHSA is going when they put out that final rule. Does that answer the question?
Hi, this is Julie. I'm just wondering, I guess I joined a little late, so do you know how we submit the comments?
Yes, if you go to, on the slide that's shown now, if you go to the Federal Register notice, okay, there's a link to sending comments to SAMHSA.
Okay, thanks.
And Rulin, I think you wanted to know the deadline here. It's also posted 5 p.m. April 11th. And
Eastern time. Yes.
That makes a difference.
I know.
Okay. So again, Maureen's email is there at the bottom of the screen, maureen.boyle@nih.gov. Maureen, thank you. The information was great, timely. The participation was good. I'm going to post the recording of this presentation so others can see this again. Give me about 10 days to post this. The librarians will help me to get it up online at the CTN Dissemination Library under the training section. Carmen, did you have any closing comments?
No, I just want everybody to please take a look at the proposed rule and to submit comments and questions to the Federal Register link, as it do apply to our stakeholders quite a bit. And thank you, everybody, for participating, and thank Maureen for giving the presentation.
Yes, and thank you all.
Thank you. Our next topic will be March 23rd in 2 weeks on the challenge of evidence-based group therapy for substance use disorders. And Dennis Wendt will be our guest speaker at 1 o'clock p.m. Eastern Time. So we invite everyone to come back again. And again, Maureen, thank you for joining us today. And everyone, thank you for the interchange of comments. This will end our presentation today.